Good morning, delegates. Good morning, everyone. Thank you for joining Shield Connect. And today we are meeting with a new series, a virtual learning series on Preeclampsia, VLSP 2022-23, sponsored by the Society for Maternal Fetal Medicine India, MFM. So before we start with the session, let me introduce our moderator, Dr. Anu Joseph. So Dr. Anu Joseph is currently consultant and medical director of Trinity Healthcare Clinic, Electronic City, and ma'am is also consultant in Kaveri Hospital of Ma Kaveri Unit in Electronic City, Bangalore. Ma'am is also visiting consultant of fetal medicine in Aspire Fertility Center, HSR Layout, Motherhood Hospital in Sarjapur Road, Narayan Multiple Specialty Hospital in HSR Layout. An area of interest is first trimester aneuploidy screening and prevention in high risk pregnancy. Ma'am is also awarded with by EC member SMFM and event coordinator of VLSP 2022-23. So I welcome you, ma'am, on our platform, and I will hand over the session to you, ma'am. Thank you, ma'am.
Thank you, Nishan. Thank you for that wonderful introduction. Hello, everybody. I'm Dr. Anu here. Welcome you all to the first session on the virtual learning series on preeclampsia, which is short named as VLSPE. Today, the topic that we are going to discuss about is on the basics of preeclampsia, revisiting the relevant. We would be having the way how we are going to arrange this is that initially we would have Dr. Prakash Mehta, our president of SMFMI, to give us all a welcome address. And that we would be followed in with a short soundbite on measuring the blood pressure. And then we would go into our panel discussion on definitions, classification, and risk factor of preeclampsia. After which we have a surprise event of expansion of SFMI. I wish all of you can stay over and join us through this entire journey. First of all, I invite Dr. Prakash Mehta, sir. Sir has been our guide, mentor throughout our journey in high-risk pregnancies and fetal medicine. At present, sir is the Chief Division of Maternal Fetal Medicine, Head of Department of OBG in Bhagwan Mahavir Jain Hospital. Sir is also the President, like I said, for our society, the Society for Maternal Fetal Medicine India. Sir is a co-chair for our educational program, Preeclampsia Education of the Nation, Penai. And sir is highly interested in high-risk pregnancy management. Like all our students, all his students would vouch for him. He has been the best teacher that any one of us could have. And he has had that vouch for him by the Bangalore Society of OB-GYN, and he has received a Lifetime Achievement Award from BSOG in 2021. Sir, I would invite you to give the welcome address for today's talk.
Good morning, everyone, and thank you, Anu, for that introduction. Today is the World Preeclampsia Day. It was exactly 1 year ago in 2021 that we inaugurated our Penai program. Penai, incidentally, is Preeclampsia Education of the Nation, India. So that program, which we will have a little more details during the course of this meet, but basically it consists of 6 modules followed by a assessment test and then a certification, which is jointly given by the Society for Maternal Fetal Medicine of India, as well as the International Society for Study of Hypertension in Pregnancy. Now, when we started this Penai program last year, we were not really that big. We were just taking our initial baby steps at that particular time. Now, over 1 year, I think we have grown exponentially, and our certification course has been very well received all over the country, and we have been certifying delegates from all across India. Our aim was to ensure that the preeclampsia women are treated in a much more rational way than what is going on now. And I think we are very close to achieving that goal. Before I go further, I would like to say a few words about some of our well-wishers and guides present over here. The first one is I welcome Dr. Sarosh Rana, Professor, University of Chicago. She has and also a co-chair of the Penai program. She has joined us from US, almost running into midnight, trying to be with us. Thank you, Dr. Sarosh Rana, for being with us. I have in my panel, I have three very great members, I should say. One is Dr. Jayam Kannan. I'm sure most of you know who Dr. Jayam is, a very, very senior member and a former vice president of Foxy, very enthusiastic person. We have Dr. Tamkin Khan, from a professor from Aligarh, whose main interest and who incidentally also is the founder secretary for the Society of Prevention of Stillbirth. We also have Dr. Sushma Dev from Mysore, professor of Mysore Medical College, who is going to inaugurate her chapter of SMFMI in Mysore today. They are going to inaugurate that chapter today. I also welcome Dr. Preeti Kumar, our Foxy State Motherhood Committee chairperson, and Dr. Anju Agarwal, again from Lucknow, professor at King George's Medical University of Lucknow. Then we have Dr. Sarvana Kumar from Salem, professor from Salem, and we are hoping to start our next chapter in Salem in the next meeting. So we are really very happy about with all that love the members from all over India have showered on us, as well as the enthusiasm with which they are sharing our passion of preventing maternal and fetal morbidity and mortality in preeclampsia. So today's program, this program, what we are having now is distributed over 6 sessions, and we are going over from basics to absolute management of absolute complications. Today's program would be we'll be going through the various definitions and classification, the confusion, because there are so many definitions for preeclampsia. There are so many classifications for preeclampsia, which have changed over the years. So to try to get, get something out of this confusion is what today's program is meant for. And I have to thank Shield for supporting us, becoming our educational partners in this particular program. Okay, Anu, with this, kindly take over the proceedings further.
Thank you so much, sir. Next, I would like to introduce all our August gathering on the dais. Dr. Sarosh Rana, welcome you, ma'am, to the first event on the virtual learning series. Madam is the section chief, maternal fetal medicine department, professor of OBG in the University of Chicago. Madam is also the co-chair of the Global Health Committee at ISHP. She's an international advisor for our society, the Society of Maternal Fetal Medicine India. Madam's area of interest is preeclampsia research, and Madam has done a lot on it, clinical applications of angiogenetic biomarkers in pregnancy and postpartum. And she has been awarded as the Mentor Award for Sustained Excellence in Mentoring. She has been awarded Castle Connolly's Exceptional Women's Award in Medicine and Castle Connolly's Top Doctor Chicago Award in 2020. Welcome, ma'am.
Thank you very much. Thank you. It's amazing to be here.
Thank you. Next slide, please. Next, I would like to welcome our own Dr. Revati Rajan. Madam is a specialist in maternal fetal medicine, and she works currently as a chief consultant as maternal fetal medicine at Mirror Health, Bangalore. Madam is also a visiting consultant in Milan, BMJ, TCH, and NMNC Bangalore. Madam is a secretary, the Society of Maternal Fetal Medicine India, and also the co-chair for Penai. The areas of interest is hypertensive disorders in pregnancy, with particular interest in preeclampsia and in utero programming. She has been a great orator, receiving the Yuva Foxy Award, Yuva Foxy Award in 2015, 2016, and has been given Certificate of Excellence in the categories of Research and Young Scientist at the 2nd Academic Brand Awards, New Delhi. She's also been awarded as the Incredible Researcher of India, September 2021, and holds a record in it. Welcome, Dr. Revati, to it.
Thank you, Dr. Anu.
Next on dais, I would like to welcome Dr. Tamkeen Khan. Madam is the professor, JNMC, AMU Aligarh. She is a founder secretary of Stillbirth Society of India. I've been told that she holds that quite near to her heart in the research for stillbirth in India. Area of interest has been high-risk pregnancy and fetal medicine, medical education, and medical humanities and quality improvement. Madam has been awarded the Innovations and Implementation through Government Policy Signature Award of Thomas F. Brooke. She has been awarded she's authored 6 award-winning papers, including the paper on respectful maternity care at RCOG Virtual World Conference in 2021. And like we've already mentioned, she's a founder secretary of Stillbirth Society in India. Madam, it's an honor to have you here. Welcome to you, Dr. Tamkeen Khan. Next, I would like to invite Dr. Sushma Dev. Like sir has already introduced, Madam is the Associate Professor at Mysore Medical College and Research Institute. She's a Director and Chief Consultant at Aishwarya Hospital, Mysore, and is working as the Secretary, Mysore OBG Society, 2020 to 2022. She's also the chairperson and chairperson to the quiz committee of Kasoga and member of endometriosis committee of FOXY, member of MTP committee of FOXY. Area of interest is infertility, high-risk pregnancy, and gynec endoscopy. She has presented papers and has been a speaker at various state and national conferences and has published several articles in international journal. Welcome, Dr. Sushma. Dr. Jayam Kannam requires probably no introduction to all of us. Madam is the professor at MGR University, Trichy. She's also the course director for Fellowship in Reproductive Medicine of FOXY. Madam is the managing trustee of Garbharakshi Group of Institutions and management member of Partnership of Maternal, Newborn and Health and Child Health Society from the WHO. She is interested in long-term follow-up of PCOS and started the study in 2001 and currently has almost around 1,000 plus patients on follow-up. Madam has been recognized as one of the best administrator in terms of best society president, best society secretary, and she has remained as the president and she has achieved the President of India Medal for Outstanding Performance in MBBS. She's been a great student, a great teacher, and a great leader. Welcome, Madam. Again, from our own SFMI, I would love to welcome Dr. Sunita Mahesh. Madam is a medical director and senior consultant of maternal medicine in Milan. And her interest is in high-risk pregnancy, ART pregnancy, a combination of them, high-risk ART pregnancy and management of recurrent pregnancy losses. Madam is an executive member in BSOG as well as in SMFMI, and she is a chapter formulation coordinator with us in SFMFI. Welcome, Madam. With this, I would invite Dr. Revati to first give a small audio talk or the capsule on the topic today, which is measuring of blood pressure, the do's and the don'ts.
A minute before Dr. Revati really starts her talk, I would request Dr. Sarosh Rana to say a few encouraging words regarding the Penai as well as the SMFMI. But before I ask her to begin her address, I have to make two very great announcements. The first one is that we are coming out with a book on hypertensive disorders of pregnancy in association with the International Society of Obstetric Medicine, which includes Dr. Kenneth Shen from Rhode Island and Dr. Ganeshan from Malaysia as co-editors, apart from myself and Revati. So we are hoping to release this book over a period of next 1 year. And the second and the more exciting announcement that I have to give today is that the International Society for Study of Hypertension in Pregnancy will be holding its international conference in 2023 in Bengaluru. So we are really touched, Dr. Sarosh, with the amount of trust and that you have shown in us that we would be able to pull off this international event, because this is a very directed and a very focused event, and we are likely to have quite possibly more foreign delegates than Indian delegates. And it's a big responsibility, and thank you. And I'm sure my young team will definitely live up to it.
Thank you, Dr. Sarosh.
So thank you so much for your kind words, Dr. Mehra, and thanks everybody. So welcome everyone to the virtual course. I'm not actually giving any lectures here, but yeah, I mean, we can talk a little bit about our journey. So it's been a long journey now. I don't know how many years I've known Revati. We, a while ago, and it's just like, when I think about it, it was just a small conversation. I remember I was sitting on a table. It was an iShip meeting. I'm trying to remember where it was. Maybe it was in Germany. It was somewhere else. I don't know, wherever the meeting was. And Revati comes and says, "Oh, I've heard so much about you. Can you please work with me?" I can tell you there are so many people who are randomly emailing me, calling me all the time and saying, "Can you please work?" And nobody ever follows up. So you say, "Yeah, sure, we'll work together." Then that's what I told Revati. And next thing you know, she emails me nicely asking all kinds of stuff. And we've been working ever since. So I think, one of the kind of take-home messages that we as healthcare providers, we all take care of women and high-risk women or even low-risk women. I think the two things that I feel will definitely make long-term impact is, one is creation of a society like you guys have done in terms of SMFMI. So not only just like be a expert yourself, but have this responsibility to train the next generation. And that's what I take most of the pride in terms of training my fellows. So that's an excellent job that you guys are doing. And thanks for all the people who are trying to now institute SMFMI at their institutions, even if it's local and regional. I think that is something that the knowledge that we need to pass on to the younger generation so they can actually get up to speed. And the second thing is, I think the Penai course is just amazing course. And again, it just started out by a conversation with me and Revati and Dr. Mehra, and then it became really a thing. And I can say that so much of effort, and not so much my effort, I think so much of the effort from the team that has gone into this in terms of just organizing even this meeting has been amazing amount of work. So you guys are doing this excellent. So I'm so proud that it was such a great feeling when we came for the first delegates when they were graduating. It was so amazing to see all these people who did the course. I think it's amazing. And thanks for everyone to come and join today. I think, together, I would say that, we don't have treatment for preeclampsia right now. There's not great biomarkers. But I think through education, we can at least start out by diagnosing it correctly, trying to prevent it, trying to develop protocols in your own hospitals for management of hypertension, intrapartum, postpartum, antepartum. I think those are the things that we can definitely learn and try to do it for every patient every time. So I will stop there because I don't want to take more of your time. And then I have full faith in you, Dr. Mehra and Dr. Revati, because that's what I told the iShip committee. I'm like, okay, can we just do this in India and can I do it with my people? I think you guys are going to do a great job with the iShip meeting, and I can't wait to see you all in person.
Thank you. Thank you. And with this, I think, Dr. Revati, please let's start the program.
Thank you so much, sir. And thank you so much, Dr. Sarosh, for those great words of enthusiasm and encouragement. Let me start sharing my slides. you're able to see my slides, Chitrakala?
Yes, ma'am.
Okay. First of all, I'm feeling really happy to be starting off the virtual learning series on preeclampsia, which is the first session of the 6th series program. So this session is going to be on the basics. So we are going to talk about measurement of blood pressure during pregnancy, the do's and the don'ts, and I've tried to capture most important guidelines to tell us how to measure blood pressure. What is the need to measure blood pressure and how do we do it? Moving ahead, what is blood pressure? Blood pressure or systemic arterial pressure refers to the pressure which is measured within the large arteries in the systemic circulation. We all know that we have something called the systolic as well as the diastolic blood pressure. Systolic blood pressure is the pressure that is exerted on the arterial walls by blood when heart is in the systole, which is during ventricular contraction. And diastolic blood pressure is the pressure which is exerted on the arterial walls by blood when heart is in diastole, which is during ventricular relaxation. We also know a term called the mean arterial pressure, which is nothing but the average arterial pressure throughout one cardiac cycle, that is systole and diastole. And you have a formula, and I really will also touch on how to measure mean arterial pressure when I'm actually showing you my video. So basically, the formula is diastolic blood pressure plus 1/3 systolic pressure minus diastolic blood pressure. Now, to tell you more about the different kinds of hypertension, to elaborate about the definitions is beyond my scope of this talk, but I'm going to stick on to the ISSHP definition of hypertension, which says hypertension in pregnancy is defined as systolic blood pressure of more than 140 and diastolic blood pressure of more than 90. BP should be repeated to confirm true hypertension if BP is severe, like if it's more than 160. If the diastolic is more than 160 and the systolic is more than 160 and the diastolic is more than 110, then we should confirm it after 15 minutes. For less severe blood pressures, repeat readings should be taken. Very, very important. We'll have to repeat the readings. Idealistic is to use a liquid crystal sphygmomanometer, but because of the hazards of mercury usage, we don't use it most of the time, and we use a validated and appropriately calibrated automated device. And just to touch on the definition, so we know what hypertension of pregnancy is. We know that the ISHIP, most of the organizations in the world accept to this kind of a definition. We have chronic hypertension, which occurs just prior to pregnancy. We have white coat hypertension, masked hypertension, hypertension which is arising de novo or after 20 weeks, which we classify it as transient, gestational, and preeclampsia. The most serious form, which can cause adverse maternal and perinatal outcomes and can be superimposed on chronic hypertension also. Now, with this background, I would want to tell you that there are certain physiological changes which can occur during pregnancy. We know that the cardiac output, the stroke volume, as well as the intravascular volume increases to about 40 to 50% during pregnancy, and the systemic vascular resistance decreases by about 20%. So if I'm going to actually summarize this, it's reported that arterial compliance is increased by 30% in the first trimester and remains elevated thereafter during pregnancy. So the take-home message is definitely the systemic vascular resistance is less during pregnancy. Now, what is the need to measure blood pressure? Measurement of blood pressure is essential for clinical management of patients. It is important that we do it very accurately with the right device and appropriately. And this is particularly important in pregnancy, where the physiological changes can affect blood vessels, changing the compliance. And moreover, it's very, very important because that is something that is easily available to everybody. Not everybody goes through a screening protocol. So at least we should be able to identify people who have a high blood pressure. For this reason, we need to have properly validated devices so that the clinicians are equipped with this basic measure of identifying high blood pressures during pregnancy. Now, we can actually classify the need as what is important antenatally, what is important intrapartum, why is it important postpartum. Antenatally, very, very important because we need to screen for preeclampsia, the most serious form of hypertensive disorders in pregnancy. We can predict adverse pregnancy outcomes such as fetal growth restriction or preeclampsia. We can diagnose cardiovascular diseases apart from hypertension. So if you are able to measure blood pressure on right and left arms in the first clinic visit, and this reveals a significant pressure difference, you can pick up coarctation of the aorta. And this is important because this is going to help us, titrate antihypertensives. If you're looking at the intrapartum period, it's important because we know that the blood flows from the uteroplacental vasculature to the rest of the circulation, and this increases the stroke volume, cardiac output, and blood pressure. So this is important to prevent complications such as stroke, eclampsia, and cardiac failure immediately after delivery. It's important during endotracheal intubation because the presence of hypertension is an important risk factor, which can jeopardize this particular procedure. It is important as well to identify shock. So you need to identify low blood pressures as well, and shock index, calculating the shock index much before the actual shock happens is very, very important for managing the patients appropriately and shift to a tertiary center. If you're looking at the postpartum period, postpartum hemorrhage is something that actually is very, very scary. And this is something that happens immediately after birth with the first 48 hours, 48 to 72 hours. So very, very important for us to identify this using, blood pressure measurements. Now, if you're looking at how we are actually going to measure blood pressures, it could be invasive or non-invasive. Invasive only in critical conditions like in septic shock or severe obstetric hemorrhage or eclampsia and those kinds of things. Where we use an intra-arterial device, which is used for to measure blood pressure. But the non-invasive is something that we have to use routinely in clinical practice. We use the auscultatory, we use the automated method, we use the aneroid device. Auscultatory using the sphygmomanometer, that is, sometimes, not easily done or not done preferably in all clinics. And if you're doing the auscultatory method, the Korotkov phase 1 is representative of the systolic blood pressure. So you need to directly palpate the arterial pulse while the cuff pressure is inflating imprecisely, which indicates the systolic blood pressure. But the diastolic blood pressure is indicated by the disappearance of the sound, which is nothing but the Korotkov phase 5. Now, if you're looking at what do we do generally for the auscultatory and the automated methods, very important that once the patient has come into your clinic, you make her very, very comfortable. I would rather summarize this whole thing by a video that I've actually shot yesterday in my clinic. So Chitrakala, can you please play on the video so that we can demonstrate how we measure blood pressures? I have recorded this using the automated device because this is what is routinely practiced in most of the clinics. Chitrakala, can you just play the video for me?
Here I am with Mrs. X, who is walked into my antenatal clinic. She walked into my clinic about 5 minutes before I starting to measure her blood pressure. You can see that she's absolutely comfortable. She's seated with her feet on the ground and she's absolutely relaxed with her back as well as her arms well supported on a very properly and comfortably placed chair. Now I'm going to make sure that I assess the size of her arm, and I feel it's of the regular size. I have made sure that it is less than 33 centimeters, so a regular cuff should fit her easily. I'm also going to make sure that her arm is at the level of the heart, and so is the machine. That is how I'm going to place the whole thing. You can see that the feet is on the ground and she's comfortably placed. Now I'm going to assess her. I'm going to pick up the right arm as most of the recommendations say, and I'm going to palpate her brachial artery, and I'm also making sure that I identify a point which is about 2.5 centimeters from the antecubital fossa. I'm going to make the arm rest on the table, and I'm going to insert this cuff in such a way that this cuff encircles about 80, the bladder covers at least 80% of the arm, and it is snugly tied. I have to make sure that the clothing is also properly placed so that it will not affect the tying of the cuff. With this, I'm probably going to record the with the blood pressure. I'm going to press the start button and wait for the values. This is a properly validated blood pressure meter, which is an automated device. It is very difficult for us to procure the mercury sphygmometer because of the hazards that are associated with mercury. Yes, so I have the reading. It is 117 by 69 and it is normal. Your blood pressure is normal, Mrs. X.
Thank you.
Yes. Can I move on with the slides? Should I start sharing again?
Yes, ma'am.
Yes. Can you see my slide?
Yes, yes, Doctor.
Yeah. All right. So we looked at how we generally measure blood pressures, and this was with an automated device. Make sure that you feel the pulse properly. If the pulse is not properly felt, you cannot use an automated device. And make sure there are certain other things that we'll have to keep in mind. Definitely do not use the first reading. Try to get at least 2 or 3 readings. And if in case the measurements are taken on both arms simultaneously and you have identified that both the left and the right arms almost coincide, then you can start monitoring the patient with the right arm as per the ICOG guidelines. You can use one arm. And you can also measure the blood pressures ideally in the left lateral position and not necessarily in the supine position. These are certain things that you'll have to keep in mind. And if you have recorded a high blood pressure, please repeat another time to check whether it is correct. And if you have made something like a 140/90, again, repeat this maybe about 4 hours later to make sure that it is definitely high before coming into any kind of a conclusion. So I'm not able to move. Yes, correct. So I think all this is already covered, and the width of the cuff is something that you have to keep in mind. If it is more than 33 centimeters, use a cuff which is bigger, and it should be ideally more than 15 centimeters, at least 15 centimeters. Now, if you're looking at the typical palpatory as well as auscultatory method, we usually palpate the radial artery. This is just for understanding, so that we inflate the cuff to identify pressure where the radial artery pulsation completely disappears. Then we deflate the cuff completely, and this step prevents missing an auscultatory gap. So we have identified that point where the radial pulsation completely disappears. So this is how you do the palpatory method. There is where the systolic is identified. And then by auscultatory method, you inflate the cuff up to about 20 to 30 millimeters Hg above the pressure level at which the radial artery pulsation has disappeared. Then you deflate it gradually at a rate of about 2 mm Hg per second while auscultating the brachial artery at the antecubital fossa. We know that the first sound is the Korotkov sound, which represents the systolic blood pressure, and the disappearance of this, or the Korotkov 5, represents the diastolic blood pressure. If you do not have complete disappearance, even the muffling Korotkov 4 will represent the diastolic blood pressure. So this is basic, and always tell the patient that you're measuring BP, keep her as comfortable as she can, and then at the end of it, tell her what her blood pressure reading is and tell her what the interpretation is. So these are the enlisted devices which are validated for pregnancy and preeclampsia. I did not find this in our Indian literature, but most of the times we use this Omron blood pressure monitors for the automated devices to measure blood pressure. And what you have to understand is we finished with the invasive, we finished with the non-invasive, we've understood how to do the auscultatory method, how to do the automated device. There is something called the ambulatory blood pressure as well, and that is important in the clinic where you measure the blood pressures 24 hours. Usually the patient is admitted, and this is important for the detection of blood pressure variability, aiding the diagnosis of white coat hypertension, chronic hypertension, and marked hypertension. And very important to use validated blood pressures. I'm reiterating this again and again. And there are challenges like manufacturer-related challenges, validation of the accuracy of these devices, patient-related factors, cultural beliefs, the kind of clothing they wear, and also health system-related factors, whether the patient has access to, get their blood pressures measured. Healthcare professional-related factors, very important. That is what we're trying to do with the Penai program. We want everyone to understand the small nuances as to how to measure blood pressure accurately. This is a picture, just in case my video was not going to work. And the key messages that I would want to give is due to physiological changes that occur in pregnancy and hypertensive disorders in pregnancy, blood pressure devices require proper validation. During a blood pressure measurement, an average of 2 or more readings should be taken to denote the blood pressure value, never a single blood pressure reading in clinical practice. And this is widespread. And if you just take a single blood pressure, it can impact on decision-making and compromise patient safety, very, very important. There are other factors like manufacturer, patient, health system, healthcare professional related factors, which we have to probably standardize. And you have to have an evidence-based and easy to follow algorithm on techniques of auscultatory and automated blood pressure. I would rather ask you to maybe stick something on the wall of your clinic so that even the residents would know exactly how to fine-tune their skills. And most of these, what I have told you right now, has been reiterated by the standard International Society of Study of Hypertension in Pregnancy. I don't see much of a difference in most of these recommendations. I have the ACOG practice bulletin as well. They probably ask for a 10-minute rest period, unlike other guidelines where we use something like 2 to 5 minute rest period. We also have it reiterated by the FOXI Gestosis ICOG guidelines. However, FOXI does tell us that probably we should be using the right arm once you have made sure that the blood pressures are kind of normal in both of the arms. So this is the YouTube video, and I hope I have conveyed as to what is the exact method by which we accurately measure blood pressures in our pregnant women to make the right diagnosis of the different kinds of hypertension that can complicate pregnancy. So with this, I would, get back to Anu to take the proceeding forwards. This is the YouTube link. You can probably download the video and use it for patient, the education further. Thank you so much.
Thank you, Dr. Revati, for that wonderful and elaborate presentation on do's and don'ts about measuring of BP. Yes, it is something that we need to be very, very sure about because that makes us understand how well we can measure a BP is how well we can treat a patient with hypertension in pregnancy. The next on our list is our panel discussion. I would invite Dr. Prakash Mehta, sir. Sir, please take over the stage for the panel discussion. I would also invite all our esteemed panelists to be on call and discuss the next panel, the preeclampsia, the basics.
Yes, thank you, Anu. And I welcome my panelists, Dr. Jain Kannan, Dr. Tamkin Khan, Dr. Sushma Dev, for this panelist. We are going to deal only with the basics and just try to understand what is the problem that occurs when we try to identify preeclampsia. We know that preeclampsia is one of the most significant and intriguing unsolved problems in obstetrics. So from the time of this Cahun papyrus, which was long, long ago, we have still not understood what preeclampsia is. How do we identify it? How do we diagnose it? We are still at crossroads. Now, today being the World Preeclampsia Day, I thought I had to add this slide. We know that giving birth should be a time for celebration, but more than 500 million women each year, or 1 every minute, having pregnancy or childbirth end in death and mourning. 6% of preeclamptics develop 1 or more major systemic complications. And we know that it is a multi-system progressive disorder. Unfortunately, the father of preeclampsia, Chesley, when he wrote his book on hypertension, he said that once the patient delivers with preeclampsia, the preeclampsia comes to an end. Unfortunately, now we know that it is not true, and a pre-eclamptic woman needs lifelong care and follow-up. And the most important thing is that the many maternal and fetal deaths or near misses are associated with substandard care. So this is the history. We have been, as I told you, struggling from 2200 BC till today. How we don't know what preeclampsia is. Okay, and these are some of the famous people who have worked in the field of preeclampsia, and I'm so happy to note that at least 2 of them are of Indian origin. So I'll just give you a few cases to our panelists so that to know how the definition could be confusing. Now, this is the story of a 33-year-old G5A4 with 34 weeks, referred with IVF conception and a high blood pressure of 160 by 110 millimeters of mercury. Appreciating fetal movements well, history of bilateral lower limb swelling for the last 2 months, no symptoms of severe PE, hematology and biochemistry essentially normal, urine albumin 1+ with 6 to 8 pus cells. She was steroided and delivered as hypertension started worsening. This is another type of presentation. A 32-year-old para-2 living 1, abortion 1, IUD with oligamnios and abruption. Previous BP readings normal. Massive PPH. She came to me post-expulsion in shock. Multiple transfusion. Fibrinogen infusion had to be given. Post-shock, the BP was high. Once she came out of the shock, the BP started going up and she had to be controlled with tablet Amlong. And BP remained high for 4 weeks and then only it settled. This is the third kind of a presentation, a primigravida with 38 weeks of gestation, 2.5 years married life, spontaneous conception on first, second and third trimester were uneventful. No history of pedal edema, headache, epigastric pain or blurring of vision. One reading of 140 by 90. The biomarker glycine which was done on her was abnormal. Serum uric acid was the only test that was raised. 2 weeks growth lag, not too bad. Doppler, just a reduced umbilical uterine artery flow. Patient started developing hematuria next morning from 7:30 a.m. Then she had a tachycardia up to 110. Then the BP went up to 180 by 100 millimeters of mercury. At this stage, magnesium sulfate had to be started. She was delivered by LSCS, and post-op the BP remained high and needed antihypertensives. This is another kind of a case where a 25-year-old primigravida referred with 28 weeks of gestation, well booked, had only some amount of edema for the last few days, epigastric pain for 2 days, which was treated with antacids, did not improve, admitted in the afternoon. At that particular time, the BP for the first time touched 140 by 90, and she had severe abdominal pain. In that nursing home, a pan injection was repeated. At 11 p.m. in the night, she had convulsions. That was the time when they catheterized her. There was hematuria. Platelet count sent at that time was 46,000. She was now starting to have frank hematuria. A diagnosis of HELLP syndrome was made. Then she was referred, and post LSCS, she had massive intracerebral bleed, and she expired in 6 hours after reaching my department. A further kind of a case of primigravida with twin gestation, history of amenorrhea 8.5 months, bilateral lower limb swelling since 20 days, no history of elevated blood pressure or excessive weight gain, headache for 1 day, vomiting of 2 episodes, followed by 3 episodes of convulsion, and she needed 18 transfusions, needed to go on a ventilator, but ultimately everything went fine. And finally, this was a 30-year-old lady, primigravida, married life for 1 year, identified as gestational hypertension at 4th month, started on tablet labetalol, 100 mg BD. Her BP was 180 by 120, so she was referred to my unit. Secondary causes of hypertension were ruled out. Increased the dose of labetalol to 200 mg BD. BP continued to rise. Urine albumin became 2+ at 30 weeks when it was diagnosed to be a superimposed preeclampsia. She had IUGR, and finally she needed an LSCS at 30 weeks because the blood pressure was beyond control, and she delivered a baby of 920 grams. Of course, in this patient also both mother and baby could be sent home. So having seen this kind of various kind of pictures in preeclampsia and having the various preeclampsia definition, we know Chesley defined it in 1985, Brown in 2000, Aycock came with one definition in 2002, The working group on high blood pressure came out in 2000. Khan came in 2007. National High Blood Pressure Education Program of RCOG in 2006. And then Vatin in 2004, WHO in 2006. And after that, of course, we had many more definitions of preeclampsia. Now, then I'm sure most of even my panelists were postgraduates, and definitely when I was a postgraduate, the classical obstetric teaching characterized eclampsia as a single pathophysiological entity with the defining features of hypertension in association with proteinuria. So that was how our definitions were very simple. And you could see that the cases I presented, the definitions are of this kind of a definition will definitely not fit. So with this, I take the first question to Dr. Jayam Kannan. How would you define preeclampsia?
Yes, as you said, 40 years ago, whatever definition you first held was with me. But now, in 2022, enormous changes in the definition has gone up. The definition is now patient-centered, symptom-centered, and the guidelines which you are comfortable with, and also medical legally oriented. If we take the Indian scenario now, the Lakshya guidelines has come up very clearly that 30 plus of systolic blood pressure and 20 plus of diastolic blood pressure, if you have recorded, that is, if you have recorded a 90/60 blood pressure at any time in that pregnancy, and you are now recording 120/80 or 85, why did you not treat the patient for hypertension in pregnancy? Why did you allow her to go for growth restriction and convulsions when you recorded 130/90 in your outpatient? So the doctor is being told that you have not looked after the patient correctly. This is the latest Indian scenario, Dr. Prakash, apart from what we have as a 30 rise and other things. And even the American Heart Association has come out very clearly, 130/80, please be careful. So nowadays, I have started looking at the blood pressure, pre-pregnancy, post-pregnancy, every visit, recorded by my own colleague or myself, and look at the change for the definition of hypertensive disorders in pregnancy.
Absolutely, madam. Unfortunately, what happens in the practice most of the time is that we do not bother to check the blood pressure ourselves. We ask our senior residents, and the senior resident will ask the junior resident, and junior resident will ask the intern, and the intern will finally ask the third-year medical student to check the blood pressure. And that blood pressure comes to us, which could be right or which could be wrong. So, Dr. Sushma Dev, would you agree, or you want to add something? Would you like to add something?
Yes, Dr. Mehta. Actually, preeclampsia, as Madam has already told, looking into our older definitions, hypertension and proteinuria were the classical features to define the preeclampsia in pregnancy. But when you look at the current guidelines in defining the preeclampsia, and because we see an array and different presentations of the patients, we cannot literally fix up to us for single definitions or the two criteria to define the preeclampsia. So apart from rise in the blood pressure of SBP of more than 140 and diastolic blood pressure of more than 90 or more, it is important that we add on the other features. The presence of proteinuria is a supportive evidence, but in the absence of proteinuria also we need to define preeclampsia, especially when there are features of maternal multi-organ affections. Maybe it can be a renal affections where you just observe a rise in the creatinine value, or liver affections which can be a minor rise in the liver enzymes, and also of course the neurological symptoms of the women's, which are maybe a persistent headache, which it will also add to the inclusion of the preeclampsia. And very importantly, we also should look into the chronic affections, the maternal or fetal affections, especially the history of stillbirth, if she presents with the stillbirth, or a presence of IUGR or the Doppler changes should be considered to define the preeclampsia. So we really don't depend on proteinuria alone to define the preeclampsia. We have to look at the women as a whole, and complete obstetric involvement should be looked in when we define the preeclampsia.
Absolutely, we don't look upon it as a single disease, but possibly it's an angiogenic placental syndrome, and we need to keep that in mind. Then only we are going to be able to identify all our patients. Now, any of our panelists can take up this question. Why do you think a clarity is required in definition? What is the importance? Why should we all know what is the definition? Anybody, please.
So, clarity is required, number one, for making a diagnosis, for establishing treatment guidelines and protocols, as well as for looking at the outcome, what is happening at what cutoff level. So that is very important that we establish clear-cut, criteria for diagnosis.
Yeah, absolutely. Because even for auditing what we are doing, we definitely require a proper definition, because somebody takes the definition as 140/90, somebody takes it at 150/100, or somebody takes hypertension is not required at all, somebody takes in only blood pressure and does not take in the symptomatology, then the outcomes are never going to match, and we are not going to get a clear idea of what's happening across the world. I think this goes to Dr. Tamkin Khan. Partly it has been answered by Dr. Jayam, but increase in systolic BP by 30 and diastolic BP by 15 was used before. I think somewhere around 2000, this kind of a definition had come in. Is it
I would like to slightly disagree with Dr. Khan, slightly, though she is very right that these women may end up as SGA or low birth weight or FGR. So basically, the thing is that ACOG also cautions, that these women with relative rise in systolic or diastolic, they should be under close observation. But broadly speaking, most of the guidelines do not agree with this, and they say that it has no or not much significance, and it has a very high false positive rate. And why it is so? Because if you look at the normal physiology, in the first trimester, there's a decrease in blood pressure. Again, the second trimester, it continues right up till 32 weeks. And then it will again revert back to the normal. So because of this, it will result in a high false positive rate and too much monitoring and investigations. But definitely those women who have hyperuricemia, who are small for gestational age, or those women where there's a steep rise, these women definitely should be kept under observation and monitoring.
Do you feel, Dr. Tamkin, that the moment my patient's blood pressure rises by 30 systolic or 15 diastolic, I need to do a complete hematology workup on her, or do I have to keep on following her up with repeated scans to identify FGR? Do I need to do it, or I don't need to do it?
There is no systematic evidence that it will result in adverse pregnancy outcome, and that is what I was saying, that because there's a very high false positive, but definitely if it's a steep increase, or it is associated with certain conditions that I just enumerated, we do need to keep a close monitoring. But broadly speaking, all guidelines do not say that this is going to result in adverse pregnancy outcome.
Right. So the last word is not out yet. But even I would agree with Dr. Jayam, because in my practice, what I've observed is the moment the blood pressure could be very well within 120/90. But most of our Indian women have a blood pressure of 90/60 when they come to you in the pre-pregnancy period or in the very first visit. It is 90/60, and later on it increases. You see some of them, not all of them, but some of them do land up. So what I would say is we just follow them up a little more carefully. Hematology workup, fine, you decide. But depending on how the blood pressure is changing, but at least follow her up very carefully. Okay, so this is one of the articles which says, yes, it has a sensitivity of 92% and a specificity of 44%. Like what Dr. Tamkin said, the specificity is not there. But there is some amount of sensitivity, which is high. So we need to be a little more careful with this patients. Yeah, Dr. Sushma, how would you classify hypertensive disorders in pregnancy? I'm asking overall hypertensive disorders, not just preeclampsia.
Yeah, because hypertensive disorders have been classified with many societies, and currently ISHIP classification is the one which holds good, and because it takes into considerations the overall different ways of presentations and different classifications. And currently we look into as primarily as chronic hypertensions that presents before 20 weeks of pregnancy or prior to the pregnancy, and the other one is which presents after 20 weeks of gestations. So in the chronic hypertension category, we have the essential or a secondary hypertensions, and most of the situations it is the essential hypertension which presents. And also in this category we have two important entities which have not been looked into, or which have not been observed by most of the clinicians, that is the new definitions, that's the white coat hypertensions and the masked hypertensions. Because in your clinical scenario of presentations, we also need to observe the patients how they present to us. And later on in the hypertension that presents after 20 weeks of gestations, we have primarily gestational hypertension. In that also transient gestational hypertension, wherein the patient has a hypertension in sometimes, and later on she will have a recordings of normal blood pressure, and gestational hypertension, which most of us, which all of us are aware. And then we have the classical preeclampsia. So this is the current recommended classification of hypertension.
All right, Dr. Tamkin, we brought in a word called gestational hypertension. What is gestational hypertension? How is it different from preeclampsia?
So the clinical diagnosis is with a blood pressure of more than equal to 140 systolic or more than is equal to 90 diastolic is gestational hypertension in the absence of proteinuria or evidence of target organ damage, and at or more than 20 weeks of gestation. So about 7 to 15% of women will have this gestational hypertension. It may be a part of chronic hypertension, or it may be a case of evolving preeclampsia. So these women will need monitoring, and about 50% of these, 10 to 15% will develop preeclampsia later on, especially if this is happening at less than 34 weeks, or it is associated with Doppler artery abnormalities. And it needs to be treated, and the history, examination, and lab workup has to be done every week, or more frequently, depending upon the condition of the fetus, whatever monitoring you need. And at the same time, you have to manage it as just like preeclampsia with non-severe features that is terminate around 37 weeks. But if the blood pressure is more than 160 or 110 diastolic, then you need to treat it as potentially preeclampsia with severe features. You need to manage the hypertension immediately because of the risk of cerebrovascular accidents.
In your practice, Dr. Tamkin, could you tell us of all the gestational hypertension you are seeing, how many of them landed up with preeclampsia? I'm asking for your experience.
So I think of all the hypertensives that we see during pregnancy, about 10 to 20% would be only gestational hypertension. But I think it depends upon the frequency of antenatal visits, because or the monitoring that we are doing, because sometimes they will not revert back for 2 months at an end, and we have not recorded, they will come directly, because I said half of them will be evolving preeclamptics. So if we see them earlier or more regularly, the incidence will be higher. If you are seeing them only at the end of the term, then definitely it will be already an evolved case. So we will not have so much incidence of just simple gestational hypertension.
So what we have learned so far is, if you have a patient with gestational hypertension, don't panic, don't scare the patient, but follow her up very, very carefully, because she could be an evolving preeclampsia. Next to Dr. Jem Kannan, again back to you. What is preeclampsia?
This is a very, rather I will say, in pregnancy, unless we have been on a regular follow-up, it is a hair-splitting difference between gestational hypertension and preeclampsia so far as the patient is concerned. Unless we are doing all the proper investigations in these patients and go for a preeclampsia as a diagnosis with the classical symptoms of all the other things, like looking for a patient as such, even a proteinuria, if it has been not existent before and it has now started showing, has to be included in the preeclampsia level. Looking at all the other parameters by laboratory evidences, if you are going to show that the patient has developed more than 300 milligrams of protein in urine, we have to say that she is preeclamptic. Apart from this, a patient who has got a BP which is raised to more than 30 systolic and she complains of a headache, or she complains of an epigastric pain, or also all these 5, feeling, I'm not all right, madam. Somehow I feel uncomfortable. This sort of a thing, or a sudden occurrence of even a vomiting in the 2nd or 3rd trimester, which she has never experienced in the previous pregnancies, all these things, I will put it up as a preeclampsia. Maybe a textbook may say about preeclampsia with the protein alone. I'll put all these 5 symptoms also in the jar of preeclampsia. And the minute the patient comes with a feeling of mental confusion, I will rather be worried that she is going to give me trouble by a kick.
Okay, we have covered this, so I think I'll skip this question, the difference between gestational hypertension and preeclampsia. We covered it in detail. Okay, next to Dr. Thamkin again, what is superimposed preeclampsia?
So when a patient of chronic hypertension develops features, new onset proteinuria or target organ damage, we call it superimposed preeclampsia.
What if the patient has already had a proteinuria? You have a patient, let's say, with glomerulonephritis or
worsening proteinuria.
Absolutely. So if your patient has a worsening blood pressure, as we saw in one of the patients, or a worsening proteinuria, then think in terms of superimposed preeclampsia. 20 to 25% of all chronic hypertension pregnancies are going to land up with superimposed preeclampsia. So if you have a patient with chronic hypertension, you have to be very, very careful with them. Okay, now one more basic question. Dr. Jayamkannan, what is preeclampsia without severe features? You know, our definition, our terminologies have changed. We used to call it as mild PE, moderate PV, severe PE. Then we called it as non-severe PE and severe PE. And now we have changed it to PE without severe features. So how would you define that?
We have now started clarifying as non-severe hypertension, or we will say non-severe preeclampsia and severe one. If you have a record of blood pressure, which is you record between 6 hours and then within 24 hours, it remains the same of 140/90 or 130/85, as Sanjay Gupta puts it up very clearly, that Indian woman, be careful with that itself. And that a patient who never had a previous blood pressure, if supposing within 24 hours, she doesn't show any much of changes, she doesn't come out with any other features, it is a non-severe hypertension. And in that non-severe hypertension, if she shows the same level of proteinuria with 0.3 grams and urine dipstick test not showing more than 2, she doesn't have absolutely any complaints. As I said, headache, vomiting, acidity, right side pain, or a state of mental confusion, or she is very alert. All those things means non-severe hypertension. And if our laboratory tests are with striking within our parameters of the levels, which we say from minimum to maximum, that also means the patient, we are meeting with the patient of 140/90 blood pressure, mercury, but still she is not a severe hypertension.
I think that is a very, very clear-cut answer. No premonitory symptoms, no normal lab tests, and a blood pressure of 140/90. If you have in a patient, possibly you should think in terms of a preeclampsia with non-severe features. So Dr. Sushma Dev, what is preeclampsia with severe features?
Yeah, in a newer context, we classify the preeclampsia as preeclampsia without severe and the preeclampsia with severe features. Preeclampsia with severe features, which implicates that the patient is bound to have adverse maternal and the fetal outcomes. Very importantly, if the BP was previously 140/90 and suddenly there is a shoot up of blood, even a single reading of more than 160, 110 is a significant thing to call the lady as severe preeclampsia. For that situation, you should not wait for 4 hours or 6 hours to confirm it as a preeclampsia. You can just wait for 10 to 15 minutes, and if you again record the BP as 160, 110, and even a single recording is good enough to call it as a severe preeclampsia. Maybe in a short time she might throw a fit or convulsions and she might have an abruptions, because you have to be very cautious when we deal with these women presenting with severe features. When we look into the laboratory criteria, so very importantly, the abnormalities, that's the thrombocytopenia, that is platelet less than 1 lakh, and features of renal affections, that is the creat more than 1.1, because we have to understand that creat, obstetric values of the creatinine are very important. In normal pregnant, 0.8 is the normal. Anything beyond 0.8, you have to be very cautious when you analyze the creat of the women. And also the liver enzymes, when it is elevated more than twice the normal limit, it puts the lady under the severe categories, and these are all the components of the HELLP as well. And the lady presenting with breathlessness, pulmonary edema, again, any of these features will put the lady as severe. And also a new onset headache, that is she might be a candidate to throw a convulsions or eclampsia, which is not relieved by the normal paracetamol dosage. You have to consider that lady as a severe features. These are the components which puts the woman as a candidate for the preeclampsia with severe features. And very importantly, the visual disturbances. Suddenly she says that my vision is impaired, I'm not able to see, and the features of blindness and epigastric pain, abdominal discomforts, excessive vomiting, any of the immune symptoms will put the women as preeclampsia with severe features.
Yeah, Dr. Sushma, thank you for bringing out that one point very clearly. Is if you get a patient with a blood pressure of, let's say, 160, 110, 160, 120, just to meet your definition criteria, don't wait for 4 hours to recheck. It would be absolutely silly to do that, because in that 4 hours, she's going to have a lot of problems. You are not too sure about your reading, wait for 5-10 minutes, let her relax for some time, and then you immediately check it up. Okay, now this is the next question. When we talk of severe preeclampsia, should albuminuria be included? Should FGR be included, Dr. Tamkin? Because these were there once upon a time. Now they have been removed from the definition. What is your opinion? Do you think albuminuria is important? Do you think FGR is important?
So albuminuria, definitely it has been removed from the definition, because many women will have other evidence of target organ damage, or will fit or seize, and will develop complications even in the absence of albuminuria. So that is not essential for diagnosis. And FGR, because it is treated in a different manner altogether, that has also been, that will depend upon the findings of the Doppler studies and the monitoring that we are doing for the fetus. So that has also not been included currently in the definition.
Okay. Okay, the only HELLP continues to include FGR, since both preeclampsia and growth restriction are manifestation of a primary placental disorder. So although ACOG does not include FGR, HELLP continues to include FGR in their definition. For the lesson for us to learn is that if your patient has got a mild blood pressure with FGR, be more careful with her than for a mild blood pressure without FGR. Okay. Dr. Sushma, what is HELLP syndrome and how often do we see it?
Yeah, HELLP syndrome is a part of preeclampsia. It is one of the severe form or the catastrophic presentation of preeclampsia. So we should not see HELLP syndrome as a different entity in the pattern of preeclampsia. That's the one point to be stressed. So the patient will have a multi-organ dysfunctions. She will have hemolysis, and elevated liver enzymes and the low platelet counts, as we have defined the severe features of severe preeclampsia with severe features. All the components fit into the HELLP syndrome. Even single component in these three will put the lady as HELLP syndrome. So this is the indication that she needs to be terminated immediately. A very catastrophic presentation can happen to her. She needs to be treated in a tertiary center where she will have a multidisciplinary management, and we have to be very careful. And it should be anticipated in any patient. She need not be a case of severe preeclampsia to be converted to a HELLP syndrome. A case of simple gestational hypertension or any simple case can get, or she directly can present as a HELLP syndrome. So every woman should be viewed as a potential candidate of HELLP syndromes. When you look at the overall prevalence or incidence, in the general public, it may be around 0.5 to 1% of the individuals present with the HELLP syndromes. But in the individuals with preeclampsia, nearly 20% will have a complication, and which they transform into HELLP syndromes. So whenever we handle in the present era, we know that hypertensive disorder are the main reasons for the maternal mortality. So every woman should be given proper vigilance and monitoring throughout her pregnancy, and at any point of the time we might be encountering the HELLP syndrome.
Absolutely. So do not ever ignore any patient. And also we should not forget that although the majority of the HELLP syndromes will have hypertension, up to 80% of them will have hypertension and or proteinuria. But there will be cases where there won't be a hypertension or proteinuria, but there'll be only the end organ damage that you will be seeing. So you need to be careful about this patient. Any patient coming with epigastric pain, any patient coming with vomiting, blurring of vision, do not ignore them. Even though their blood pressure is normal, they may have no edema, no blood pressure, no albuminuria. Just watch out for the HELLP syndrome. Monitor them a little more carefully. Okay, next to Dr. Tamkin Khan, what is white coat hypertension? What do you mean by it? And does it have any significance?
So white coat hypertension is a very interesting or rather frustrating sometimes for us, because the patient doesn't believe us. When we are measuring the blood pressure in an office visit, during that office visit,
commonly they tell you, doctor, I'm scared of coming to the hospital. That's why my blood pressure is more in the hospital.
Yeah, and in turn, she tries to convince you that there's nothing wrong with her. And basically, it's a neuroendocrine reflex of fear and anticipation that maybe something abnormal will be detected, and then she will require treatment. So when she's not a person, it is both common in pregnant and non-pregnant states. So non-pregnant, it becomes so easy because you just advise her lifestyle modifications, etc. And because there's increased cardiovascular morbidity and mortality associated with it. But in pregnancy, it becomes difficult. But it is associated with increased morbidity, risk of morbidity and mortality in women during pregnancy. So when you record it more than 180, it needs treatment. When you record it more than 160 and 100, and with target evidence of any target organ damage, then again it needs treatment. So you need to work up the patient just like a patient of preeclampsia.
Yeah, so we know that it's not a completely benign disorder and can be a potential pre-runner for preeclampsia or its complications. Okay, in one of those articles, it was found that the incidence of FGR and incidence of preterm delivery was definitely more as compared to a patient who never showed the white coat hypertension. Okay, next to Dr. Jayam Kannan, again our favorite topic. What is atypical preeclampsia?
Yeah, this is one thing which is a nightmare for every obstetrician. I think so. Because you think that this is a patient who is normally going on. Probably I recorded a blood pressure with little more than her normal of 90/60. I recorded one incidence of 120/80. But within a couple of hours, her blood pressure shoots up. She shows any organ damage symptoms, or she throws her fits. This is what is called severe atypical preeclampsia. I think one Dr. Sibal has done a lot of work on it, and I read all his articles on atypical preeclampsia. This atypical preeclampsia is one thing about which I am so much scared in all my patients who I have had a history of family history of hypertension, or in her previous pregnancy of hypertension, or she had a fetal loss, and now this time she just shows a borderline blood pressure, which doesn't allow me to treat with medicines, but still I can expect her to go in for any problem. And this is also applicable to all patients who we consider as a non-severe hypertension with a normal blood pressure, but the laboratory evidence is carrying us. We think that she is only 140/80, 140/90. She doesn't absolutely have any problems. But when we look at the blood parameters, we find the platelets, we find the elevation in the other LDH and other parameters. And creatinine is, as Sushma said, it was previously 0.7, now it is 0.9. These are the features which makes me feel, yes, I am dealing with the atypical preeclampsia. That means her direction of growth can be anything different from the normal category, which we are so far expected to, or by literature, we are diagnosing as severe preeclampsia or imminent preeclampsia, that is once for all earlier used to be said, and eclampsia. So all these things go. Eclampsia is one where we get a kick, we always think of it. But all the other things, whichever we thought of it, have been lost, and in the direction can be, it can never be straight, it can be any curvilinear, it can be anything up and down.
I think we have got a very clear-cut message now from so far from the discussion is the hypertension is so stuck in our brains that when we think preeclampsia as hypertension. Please remember that you need to look for all symptoms, ask them repeatedly. If required, ask a leading question, because some patients may not tell you about epigastric pain because the friend would have told them that in pregnancy, burning and heartburn and that kind of a pain is very, very common. They may not, so they may not even tell you the symptom. Ask for leading questions if required, and I'm sure you will be able to help your patient in a much better way. Now, the next question, I think Dr. Tamkin would like to answer this. How is preeclampsia classified based on gestational age? How do we classify?
Can you just elaborate on the question, like based on gestational age? The definition preeclampsia is beyond 20 weeks of pregnancy, and the cutoff is 140/90, the blood pressure, and then it can be severe and very early preeclampsia and late preeclampsia. Okay, so early preeclampsia, that is developing at less than 34 weeks, is associated with more morbidity and mortality, and especially fetal FGR also. So, and it is a more severe type of disease with more risk of recurrence in the next pregnancy. Most of the time, the late preeclampsia that develops around term, it is not as severe, or the target organ damage may not be as severe. That which develops early, it will most of the time result in preeclampsia, it result in eclampsia, and it is associated with more fetal morbidity and mortality.
True. It is really unfortunate that most of our prediction tests predict about early onset preeclampsia rather than late onset preeclampsia. And what we are going to see in the practice, in a routine practice, is going to be a late onset preeclampsia most of the time. So that is where there is a slip between the cup and the lip. That's exactly what's happening. Okay, Dr. Jayan Kannan, is there a difference between early onset and late onset PE? Are maternal and fetal risks in both? I mean, do I worry more when my patient has preeclampsia at 29 weeks, or do I worry more when my patient has preeclampsia at 37 weeks?
Definitely, you have to worry more as early as you go on in pregnancy with hypertension and preeclampsia. If you have seen this at 20 weeks and you are seeing it 26 weeks, even that 6 weeks in the early onset, I will consider as a more complication with regard to the fetal survival and to the maternal permanent follow-up. Earlier the onset of preeclampsia in the patient, the more the problems to the fetus, because the vascular problems have been so much heavy, and the pathological changes which has already been done in the fetus in the form of its growth has been already well settled, that even if the baby is born with a, rather I'll say 30th centile birth weight, which is expected, will have much more features of the fetal origin of adult disease problems. She will show those problems compared to the person who developed the blood pressure at 33 weeks and shows 30 percentile growth of the baby. The baby, as it grows in the next 3 to 6 months post-delivery, has got a very large impact due to the onset of preeclampsia. Was it at 20, 21 weeks? 33 weeks. Leave alone the maternal complication, which we know very well. The fetal complications are the one which I am more worried nowadays. The low birth weight of a 33 weeks preeclampsia and a 21 weeks preeclampsia gives me a lot of difference.
Yeah, I think so. Now we are very clear in our mind that early onset preeclampsia is definitely more dangerous than the late onset one. Okay, now risk stratification is definitely necessary requisite for risk reduction. So what are the risk factors for preeclampsia, Dr. Tamkin?
So I think it is one of the most intriguing and still unsolved problem in obstetrics, especially regarding the etiopathogenesis or the risk factors. We know that is related to pregnancy. We know the treatment is delivery, and a number of risk factors have been identified. And we also know that a lady who's exposed for the first time to chorionic villi, who's exposed to an abundance of chorionic villi, who has pre-existing diseases of with evidence of endothelial cell damage or activation or inflammation like autoimmune diseases, or having a genetic or hereditary predisposition. So a past history of preeclampsia is the most important, risk factor with a relative risk of 8.4, especially related to the severity of the preeclampsia or the early onset preeclampsia in the past pregnancy. Then about 25 to 50% of these women will develop it again in the next pregnancy. Then the second most important risk factor is the presence of chronic hypertension, and also the severity of that chronic hypertension decides the risk and increases the relative risk by 5.1. Then pregnancy with diabetes, especially pre-existing diabetes, increases the risk by about 3.5 relative risk. Autoimmune diseases, SLE, APLA also increase the risk. Obesity, especially her pre-pregnancy weight or BMI, increases the relative risk by 2.8 if it is more than 25. Then chronic kidney diseases, they increase the relative risk by 1.8, but it is especially important to know what is the grade of that kidney disease, because the severity of that kidney disease will decide the relative risk or the increased risk. So about 60% of them with grade 3 or 4 will develop preeclampsia, eclampsia. Then multiple pregnancy, about 20% of all twin pregnancies will develop preeclampsia, eclampsia. Nulliparity, when she's being exposed to the chorionic villi for the first time, is the most important or most prevalent risk factor. A family history of preeclampsia in a first degree relative. And interestingly, if the woman herself was small for gestational age or low birth weight or preterm, she has more risk of developing preeclampsia in a pregnancy. Then advanced maternal age, more than 35, because now she will already have developed hypertension or diabetes. Then ART pregnancies, because probably the risk is more because they have metabolic syndrome, or they are PCOS, or they have diabetes and obesity. Then also ethnicity, Blacks, it is more common. Male fetuses, HIV disorders, and poor socioeconomic status and poor obstetric care are also associated with higher incidence of preeclampsia, eclampsia. And interestingly, smokers, they have a lower incidence of preeclampsia, eclampsia.
Absolutely. So the only new thing is that in 2018, the HELLP has added ART pregnancy as a risk factor for preeclampsia. So whenever you're dealing with an ART pregnancy, please look out for preeclampsia in these patients. I think we are running out of the time, so I'm going to just skip this particular slide. But let us now remember that preeclampsia is not just hypertension. There are long-term health issues involved with preeclampsia. And I think our panelists have been wonderful. Thank you, Dr. Jain. Thank you, Dr. Tamkin. Thank you, Dr. Sushma Dev, for being so clear and absolutely practically oriented in your answers. Thank you all very much.
Thank you so much. We all
Thank you,
enjoyed
Prakash, for your wonderful way of leading the panel.
Yeah, and very interesting questions, very relevant.
It all depends on how the leading is done. Thank you very much.
Thank you.
Thank you so much, sir.
Thank you so much, sir, for moderating such a wonderful panel. And thank you all the panelists for being such a wonderful panelist. The next on our agenda is the inauguration of our Mysore Society, Mysore chapter. I would invite Dr. Sunita to do the honors of this session. Dr. Sunita is our representative for chapter building in Society of Maternal and Fetal in Medicine in India. Madam, the stage is all yours.
Thank you, Dr. Anu. Good morning, one and all. Namaste, namaskara, vanakkam, and namaskaram to all. Today, May 22nd, is World Preeclampsia Day, and we, all the members of SMFMI, pledge to be responsibly caring for our women with the aim of predicting preeclampsia and preventing the adverse outcomes associated with it. To spread the knowledge once acquired is the most powerful tool to help the humanity. And yes, that is the ultimate virtue of chapter formation of our SMFMI. We believe in what Dr. Sarosh has stated, that society formation helps in an organized teaching to impart knowledge. So with this noble thought process, I request Dr. Prakash Mehta sir to say a few words on the chapter formation of Mysore SMFMI.
So good morning again, everybody. And I'm very happy that today we'll be inaugurating the Mysore chapter of the SMFMI. Dr. Sushma has been with us for quite some time, and we have been having so many academic exchanges with the Mysore Society. And today she has taken over the lead to come in and form a chapter of the SMFMI in Mysore. Ultimately, for the Society for Maternal Fetal Medicine, our aim is to spread education and ensure that our patients get a proper and a better care. That is exactly what we want. And Dr. Sushma has come forward to start this Mysore chapter. And I welcome you, Dr. Sushma. And once the inauguration is over, I would request you to tell about your team and your plans for Mysore after we inaugurate the chapter.
Thank you, sir. Indeed, it's
Thank
my
you,
honor.
sir. Yeah, thank you, sir. You have been a huge source of inspiration to all of us. Nothing can be accomplished without the blessings of Almighty. Now, I invite our own little musician, Master Aprameya, to invoke the blessings to ensure that our program becomes a successful one without any obstacles. Aprameya, please.
Sarvaswati namostute Sharade Vidyavrade 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 Prade Saraswati.
Thank you, Aprameya, for bringing in divinity to the whole program. I now request Dr. Prakash Mehta, sir, to do the honors of declaring the Mysore chapter open. Sir, please.
I proudly declare the Mysore chapter to have begun today on the World Preeclampsia Day, 22 May 2022. And now
sir, I would request you to invite Sushma and her team of the Mysore chapter.
Yes, Dr. Sushma, please introduce your goals and your team to the audience.
Thank you, sir. Indeed, it's my honor and it's pride that we are part of the SMFM society, and I've been with sir for several years, and he's such a inspirational, and he's been doing extensive and exceptional work in bringing up the preeclampsia updates, and he's a great teacher and teacher of teachers. And it's my pride that we are starting the first chapter of SMFMI in True Mysore, and we really love to and work forward with Sir and Dr. Sarosh ma'am, and it's indeed a great pride that we are starting up with the new chapter. And we have a great, enthusiastic, and well-versed team of Mysore. It's my honor that I am the president of this chapter of Mysore, and I would like to invite my team members. My secretary is Dr. Hema Priya, Associate Professor OBG, Jesus Medical College, Mysore, and she's a very academician, and it's truly honored to have her as my secretary. And Dr. Shweta Nayak, the treasurer for SMFM Mysore chapter. She's a consultant at Kamakshi Hospital, Mysore. And we have a very enthusiastic team with us, and we have learned and senior members who are part of our inspirational team, and they have always been stood with me and our team of Mysore Obs and Gynec Society. And any program and any invitations we give to our fellow Mysore OBY members, they're always enthusiastic and they always stand with us as a team, and we work forward and for the wellness of the women. We have the eminent members as our EC members, Dr. Rupa Prakash. She is the ex-professor of Jesus Medical College and presently visiting consultant at Kamakshi and Apollo BGS Hospital. And also she is the current president of Mysore Society. And we have Dr. Mamta S, associate professor at Jesus Medical College, Mysuru, very senior member. And Dr. Rashmi MD, consultant at Apollo BGS Hospital, Mysore. And we also have Dr. Madhura Prakash, consultant at Manipal Hospital, Mysore, and Dr. Aarti Santosh, consultant at Narayana Multispeciality Hospital. So this is the current crew member and my members of our Mysuru chapter. We have a whole team coming up and joining with us to venture in the field of high-risk pregnancy and to lot many works for the betterment of the women. It's indeed my pride and a lot of responsibilities given to us on our shoulders. We are truly honored to start the first chapter of SMFI in Mysore. I welcome all my team members, and we always look forward to work together for the betterment of our women.
Thank you, Dr. Sushma. Back to Dr. Anu, please.
Sir, I would request you to invite the other guests of honors to say a few words. Yes.
All right. I would request Dr. Anju Agarwal to say a few words.
Thank you, Dr. Prakash, and I must congratulate both you, Dr. Revti and Dr. Sarosh, and all those part of this team for this great initiative. This training in preeclampsia, it's really needed because in our country, we are, especially in Uttar Pradesh, we are still seeing cases of eclampsia, and people are still afraid of giving them Maxelf. We are trying to push it in the periphery. So gradually we are improving, and this training we hope will have a positive impact and we'll be able to reduce our maternal mortality and morbidity. So it's a great initiative and I really congratulate you on it.
Dr. Preeti Kumar, please.
Thank you, sir. Thank you, Dr. Prakash, sir, Dr. Revati. I've been associated with you all for a long period of time. Thank you so much for involving me in Penny as well initiative. I think I was the first one to get involved when it was started. Dr. Sarosh, we have high regards for you. We were waiting for you at AICOG Lucknow, but somehow due to COVID, you could not visit the Lucknow conference. But definitely there is always another time or next event. Thank you, sir. And I must say that I had been listening to the discussion with the esteemed faculty like Dr. Jayam ma'am, Dr. Sushma, and of course, Dr. Tamkeen. But I really want to emphasize what Dr. Anju madam has just now mentioned, that in the state of Uttar Pradesh, we have the referring facilities where the delivery loads are really very high. The delivery loads of as high as 200 to 300 per month, but most of them are conducted by the nursing officers. So it's a prime duty. If you really want to target the maternal mortality or stillbirths due to preeclampsia, we need to train those healthcare workers in actually in the basic protocols of how to take the blood pressure, because once they don't take the actual blood pressure, they are not aware. So I think that's the biggest thing, that it's the biggest knowledge and practice gap that we see in Uttar Pradesh. I'm not aware of the other states, but we need to work on that. I'm working a lot with healthcare workers and nursing officers, being to the referring facilities. I've been to the many of the remote areas, but I find that those are the people we need to really target on for preventing the complications due to preeclampsia. So thank you so much for making me part. And we would be really happy, sir, to initiate this chapter also in Lucknow. And I wish Dr. Sushma and her team a grand success, do good job. I think we have wonderful leaders like Dr. Sarosh, Dr. Prakash, and I must say Revati, being such a young OBGYN, she is working so hard. I was really amazed by the quality of work that she's doing in the prevention of preeclampsia, prediction and prevention. Thank you so much, Dr. Sarosh, and we would definitely like to have you here in Lucknow once again. Thank you. Thank you.
Thank you, Dr.
Thank you so
Preeti.
much, ma'am. Thank you so much, Preeti, ma'am.
Dr. Sarvana Kumar from Salem, or anyone else from Salem? Do we have them?
So I think Dr. Sarvana Kumar has left. He had put a message inside.
So Dr. Sarvana, the Salem chapter is probably the next one we are likely to have when we have our next meeting. As I told you, we have 6 meetings in this current session, and in every meeting we would like to inaugurate a chapter so that the preeclampsia case spread right across India in a great manner. So thank you all very much, and back to you, Dr. Sunita.
Sir, after Salem, Lucknow should be the next one.
Oh yeah, sure, definitely. It will be a pleasure.
Thank you. It is
Dr.
a huge.
Sarosh, please block your date for the day we inaugurate the Lucknow session. We would want you to be there on a webinar.
Yeah, virtual platform.
Yeah.
No virtual platform.
I would like to thank
Sarosh
sir
will be
for
here in October, and we would like to inaugurate the Aligarh chapter at that time.
Oh,
Aligarh
thank
chapter
you very
That'll
much.
be amazing.
Have more people
And-
here,
Yeah. So when sir gave me this responsibility of chapter formation, I thought it would be a huge, difficult task for me. But now I see it is paving its own pathway. The chapter formation is paving its own pathway. I thank you, sir, for believing in me. And I thank the entire team for making this whole program a grand success. Over to Dr. Anu.
Thank you and congratulations to the chapter, Mysore chapter of SMFMI. Welcome to you all. Now, another interesting and very close to all our heart capsule. It is a capsule on preeclampsia education of the nation. Dr. Revati would take you through what it means and also regarding how to go about with it. Over to you, Dr. Revati. Dr. Revati?
You need to unmute yourself.
Dr. Revati, we cannot hear you.
Yes. Can you hear me?
Yes, Dr. Revati.
All right. I think my slides are
visible.
I know, but it is stuck. Yes. Can you see this? Yeah.
Yes.
So I take this privilege to be presenting on the making of pre-eclampsia education of the nation India program, the start of which has probably led us for today's event, which is the virtual learning series on pre-eclampsia. So we started this program way back about a year ago when we launched this for the first time on the 22nd of May, 2021. And then the saga started. What is pre-eclampsia education of the nation India? It is a certification course for practicing obstetrics and gynecologists in India using teaching modules with the latest updates on hypertensive disorders in pregnancy with special emphasis to preeclampsia. And it is a collaborative project by the Society for Maternal Fetal Medicine India and the International Society of the Study of Hypertension in Pregnancy. So basically, it's a virtual collaborative certification course. It has 5 learning modules and 1 assessment module. All these can be taken by a clinician at home or in the clinic at their own convenience. It caters to clinicians and postgraduates alike. So it has all the information starting from the definition to the most latest about, and also deals with clinical management of preeclampsia. Now, who are the Penai organizers? I have already told you it is hosted by the Society for Maternal Fetal Medicine India and the International Society for the Study of Hypertension in Pregnancy. The Indian co-chairs are Dr. Prakash Mehta, who's the president of the Society for Maternal Fetal Medicine India, and of course myself, who is the secretary of the Society for Maternal Fetal Medicine India. We have the global co-chair, who is none other than Dr. Sarosh Rana, who is also the co-chair of Global Health Committee at the International Society of Study of Hypertension in Pregnancy. And thank you so much, Dr. Sarosh Rana, for supporting us end to end. And today is a reality. Why Penai? Why do we need this course? This is mainly because the guidelines, the classification systems, the management protocols are so different in different parts of the country and different parts of the world. Atypical presentations are so common. There are challenges extrapolating global research and guidelines into indigenous population. There are many implementational issues in urban and rural settings, and these were the questions that probably prompted us to tie up all this in a virtual program series. So what did we do? We did it in a module of programs and we probably had collaborative efforts with emphasis on translational research. We included definitions, classifications, management dilemmas like in a panel, and evidence-based protocols for comprehensive learning and understanding. And we tried to design the course to be very clinician friendly, and we wanted to probably make it comprehensive end to end with collaborative evidence-based information. So basically, it was a lot of effort. We started off in 2020 with an email and then probably tried to establish collaborations. First, we set up the collaborations between the two societies. Then we tried to raise an educational grant, thanks to Roche Diagnostics for providing us with an educational grant. Then we structured the project specifics. We liaised with clinicians from across the country. In fact, some of the clinicians like Dr. Preeti Kumar have been part of our program and the globe who are eminent in the field of hypertensive disorders in pregnancy. We have Dr. Sarosh Rana, we have Dr. Laura Maggie, we have Dr. Leona Poon, and we also have Dr. Michael Gravitt, who've all contributed from their areas of expertise to making this as robust as it is possible. We liaised with Medinet for content compilation, and we also worked for course propagation. It was launched on the World Preeclampsia Day last year. So it was a lot of efforts back end by the SMF, my office staff. I definitely congratulate Mr. Shrikant, Mr. Rajgopal, as well as Dr. Meghna Srinath, who was the concept coordinator. They did a lot of work, a lot of hours spent to make this a reality. We also thank Medinet for their support, and extended, we have Shield Connect, who's taking us beyond the Penai course to introduce this course across the country through the VLS series. We've had several PPI meetings. It did not happen with a single presentation. We discussed the content of each and every slide intrinsically with our team, and we also put it across to the global team, to Dr. Sarosh Rana, vetted it, and finally got the course content for the learning program. So there was a lot of collaborations, lot of emails, lot of coordination, lot of talks between faculty, lot of talks between delegates, which probably led to this effort. I'm emphasizing all this just to tell you the intensity with which we have actually worked day in and day out to make this a reality today. We are now in the pilot. I'm really glad that we have close to about 100 delegates who have enrolled to the course. We had the first live virtual convocation along with the interactive session very recently, and most of them had, all of them rather, have passed out with wonderful scores of more than 75% in their assessment. So it was really very satisfying for all of us to certify these clinicians. And we also have 2 of them lined up today who would probably give their input. So these are our first set of graduates, and future of our course, we plan to navigate beyond the pilot to reach out to all the practicing clinicians across the country and beyond through collaborations. We want to do periodic module updates to make the course more relevant. We want to empower clinicians with the latest evidence-based guidelines and research on preeclampsia who can contribute to reduction in maternal and perinatal morbidity and mortality due to the disease. We want to reach out to global organizations for extended support, and we want to support preeclampsia research in the future, which will enhance the quality of care in the country and definitely beyond. We all have to join hands to save lives. And with this, I would want to invite 2 of our delegates who have passed out recently to get their experience about what they felt about the course. So these are all our YouTube links or archives of the program so far. You can, I leave it on the screen. I can share it with all of you. You can look at the program in great detail. We also have a section on the FAQs. These are our correspondent details. We will also send this across emails after the program is over. So with this, I invite Dr. Nadeem as well as Dr. Chetana to give their inputs on the Penai program. They have recently graduated. They have recently finished the course. They're yet to finish, attend the live convocation. Chitrakala, can you please unmute Dr. Nadeem?
Ma'am?
Can you please unmute Dr. Nadeem Hussain?
Yes, ma'am. Yes, ma'am.
Dr. Nadeem, can we have you speak about the course, please?
Yeah, ma'am. Hello, everyone. I would like to say it was a golden opportunity to me to participate in this wonderful course, especially regarding the lectures by the wonderful faculties, regarding the concept of biomarkers, all the case-based approaches or case evaluations done there. That was really wonderful to me. And at the end, regarding the live interactive sessions, which really helped me to clear all the confusions which I had in my mind, which are really the day-to-day practice. That was really great, helpful to me. So I will be grateful for this course. I'd also like to thank Sir and all the faculties to become a participant in the course for me. Thank you, everyone.
Can we have Dr. Chetana? Thank you so much, Dr. Nadeem.
Hello.
Dr.
Thank
Chetana?
you, everyone. Yeah, can you hear me?
Yes, Dr. Chetana, please go ahead.
Thank you, everyone,
Introduce
for
yourself.
giving me an opportunity. Yeah, I'm Dr. Chetana. I'm a practicing obstetrician from Bangalore. Okay, I thank everyone for giving me an opportunity to air my views regarding this teaching program. I feel very privileged to have been selected few to attend such a program. It was an eye-opener for me. During regular CMEs or conference, we don't get an opportunity to hear such an elaborate talk about such important topics like preeclampsia, but this program has given me an opportunity to soundly understand the preeclampsia in detail, starting from etiopathogenesis to ending in the clinical dilemmas, which has changed my approach in dealing with patients as such. Okay, this basic knowledge is especially newer trending and clinical approach and managing tools properly explained by all these experts has in a way strengthened us clinicians to approach the patients with preeclampsia in a manner more confidently. Thank you all for your expert advice and details.
Thank you so much, Dr. Chetana. And moving ahead, SMFMI plans to get this course across to the grassroots level. We are trying to build up a course for the primary healthcare workers, the MBBS doctors, as well as doctors from Ayush, who would probably be given a course where they can probably recognize preeclampsia much earlier and do the referrals at the right time. So we're working on this course. Probably by next year, we should have it all in place, and we should have completed the pilot. Maybe we should have finished enrolling 200 delegates. So the saga continues, a lot of hard work pending. So thank you so much all. With this, I would request Dr. Anu to present the vote of thanks.
Thank you, Dr. Revati, for taking us through the Penai course. I hope it was informative, and I hope through this platform we would have more and more delegates coming in for the Penai program. So towards the end of the program, being the beginnings in the series of virtual learning, I would like to thank wholeheartedly our chief guest, Dr. Sarosh Rana, who has been a driving pillar towards our education programs with preeclampsia. Thank you, madam, for being here today, taking the time out very late in the day for you, I guess, and being with us always. Thank you, ma'am. Once again, it's an honor to have you associated with us. I would like this opportunity to thank Dr. Prakash Mehta, sir, who has been our greatest supporter and mentor, and also for being the excellent moderator for the panel discussion today. I would like to thank Dr. Revati to have taken us to the sound bite on measurement of hypertension, and also to have taken us through the Penai educational program. I would love to thank all our eminent panelists, Dr. Jayam Kannan, Dr. Tamkeen Khan, and Dr. Sushma, to have been the most learned panelists that we could have today for our program. Extending my warm wishes also to all our special guests that we had, our honorary guests, Dr. Anju, Dr. Preeti Kumar, and Dr. Sharavana Kumar, for being there with us and lending your support to our program. I would like to thank Dr. Sunita, who has taken up the opportunity to have introduced the Mysore chapter and to have functioned towards having the opening ceremony today. Welcome and thank you to Dr. Sushma Dev and her team from Mysore to being a part of our family at SMFMI. Thank you, Dr. Nadeem and Dr. Chetana, for having discussed with us your experience through the Penai program. I would love to recognize and put my word of thanks towards the members from the SHIELD team, Dr. Prachi, Mr. Kedar, Mr. Nishant, and Ms. Chitrakala, to have been the support that we could have to organize this VLS program. Thank you, Team SHIELD. Last but never the least, I would also like to thank our SFMMI staff, office staff, Mr. Shrikant, Dr. Meghna, and Mr. Raj Gopal, to have been the pillar of strength for all our communications and for all our deliberations. Thank you for being there. Thank you all. To all our participants for today. We had 100 around participants for today. Thank you all to have been a patient listener, and hopefully we see you around for the next event too. We'll be having 6 more of such lectures, one going up again to the other. Thank you, everybody.
Thank you all very much, and hope to see you next time.
Thank you, sir.
so much, sir. Thank you so much, all.
Thank you.
Thank you, Revati. Thank you so much.
Thank you, Saroshman. Thank you, Preeti ma'am. Thank you, everyone.
Thank you, everyone.